So it's now preparing to go to the live stream. Okay, we are on. Welcome everybody. Welcome at the Han International Week, International Days, the live stream. We started now with our first session, and actually it's the first dialogue in which we have a special guest from the UK, Ben Cormack. We really love to have you here, Ben. Everybody has probably heard you talk, your podcast, your videos, your blog post. We know how it is, and we really like to enter in a kind of a laugh and get some crazy and interesting conversations around here. So it's a huge pleasure to have you around, Ben. So I would say the floor is yours.
Thank you very much for inviting me, Joost. I would love to be there in Nijmegen, Nijmegen. In fact, I know it's Nijmegen. I know it's my little British joke. And I've used it. I've been to Nijmegen teaching twice before in the past, and I've used that joke on both occasions. So I won't use it ever again, I promise. But I would love to be there and feeling the energy in the room and seeing people's faces and shaking hands and having coffee and having some chats. But unfortunately, this is the next best thing. So I am going to try and, bring as much energy and as enthusiasm as I can to doing things online, because I think you probably need a little bit of extra to make it really pop. So my name is Ben Cormack. I am from London in the UK. I've been a clinician for about the last 20 years. Although I'm sure if you look at me, you're saying that can't be true. He's only just fresh out of university. I know what you're thinking. And I want to talk to you today about clinical tensions. So this is something that me and Joost discussed way back in January, I think. And it's about bringing together some of the concepts that we have within, not just physiotherapy, but therapy in general, just being a good clinician is looking at the ideas of things like the biopsychosocial model, person-centered care, and then evidence-based medicine, and how we can bring these things together. All right. So look, it's my real pleasure to come and speak to you. I am going to attempt to share my screen, and let's see if this works. We good?
Works perfect. Works perfect.
Ah, magic. The magic of the internet. How amazing is that? So as we can see there, just basically talking about these three areas. So biopsychosocial, person-centered care, and evidence-based medicine. Now, I am involved with two different companies, my own entity, which is Core Kinetic, and then another company that I work with the infamous Adam Meakins, called the Better Clinician Project. All right, so they're two things that I am involved with. Now, I see these three areas of modern clinical practice as having this intrinsic tension. And one of the things that we have to do as modern clinicians is balance these tensions. So we are told that we have to be evidence-based and we have to read our research and we have to be able to interpret it and understand our statistics. And, some of you will have done some research projects or are be going to do some research projects at the end of your of your education. Now, at the same time, we're being told about this modern biopsychosocial model. And my favorite quote around the biopsychosocial model is it's like teenage sex, right? So I have to get sex into every presentation of mine somehow. But biopsychosocial model is a bit like teenage sex. So everyone's talking about it, but are they doing it? and that's the real question. And even sometimes, what even is it, right? And then we also have this concept that I think emerges from the biopsychosocial model, which is person-centered care. And I'm sure in your education, you're being told to listen to your patient, to hear your patient. And that's part of this patient or person-centered care model. And we as clinicians have this tough job of bringing these three things together and being able to navigate and use them within our clinical practice. And let me give you the value of my experience. That's not easy. That's really, really quite difficult. And I think firstly, we have to appreciate and understand what some of these things actually are, because we pick up information like patients pick up information. Clinicians get information from the internet, from the world around them. And sometimes they're not quite exactly what was meant in the beginning. And that's no different to patients who pick up ideas about their back pain or what's causing their pain. So these things are just part of human nature. So what I wanted to do today was clarify what some of these things are, what they kind of really mean in my interpretation, and then how we can start to bring some of these things together and understand how do we reconcile these? How do we bring them together in a way that's usable for us as clinicians in the clinic with a patient, not just a textbook? All right, so that's kind of what we're going to do. Whether I actually achieve that or not, I have no idea, but we're definitely going to try. All right, so at least effort is a good thing. So let's move forward a little bit. So I think the modern clinical world sometimes is about having the answers. So we read research and I go into a clinical encounter and I've got the answer to the question. So if my patient has back pain, then I can do evidence and I can do, like education and exercise, right? I've got the answers. This is simple. But in other ways, I don't really have the answers because they're so broad as categories that we need to be able to think about how do I work with this patient, not how do I work with, education and exercise. So I think the first step that we need to make is thinking about not having answers, is thinking about having better questions. Because I think if we have better questions, then we can get the answers for this person and for this patient, not simply answers for everybody in the population. And I think that's the kind of trouble that evidence-based medicine sometimes brings us, is this idea that we're going to have this single answer for everybody out there. And actually, when you dig into the evidence, when you understand it more, when you work in clinic, you realize actually it's not about having this single answer. It's about having better questions to find the answer for this patient. All right. And I think that for me has always been a fundamental shift from the way that I was educated. I was educated to do a special test, find the pathology and fix it with an exercise or a manual therapy or an ultrasound. And I've actually developed a really amazing double ultrasound technique that I tend to do like that. And it's been quite a revelation for my practice. But let's move on and think about how we start to integrate this. So let's start talking a bit about the biopsychosocial model. And the biopsychosocial model is definitely something that's interested me over the past 10 years. And it's an area that I've delved into a little deeper. Now, why do we need the biopsychosocial model? And it was not something that I came across until I was actually graduated. It wasn't part of my undergraduate education. So let's look at why, people like George Engel and Peabody and Osler thought about why did we need this other model rather than this kind of biomedical model that we're given. And so I've got a couple of quotes. I do like quotes. I think that they are, something that give us some really good information. And so firstly, this one is from George Engel from the 70s. And actually, this was even before I was born, 1977. I was born in 1978. Engel described the biomedical model as does not include the patient and his attributes as a person, a human being. And I think fundamentally that word is really amazing. So we have that idea of the human being, the person. And I think this is what's given birth to this more modern person-centered care approach. Now, we have some further discussion from Hendrickx in 2009, and they described the biomedical model as dehumanization of modern medical practice and produces dissatisfaction of people in need of health services. All right. So I think fundamentally what we can see here is both of these descriptions of the biomedical model revolve around this idea that they are dehumanizing healthcare. that they are taking out the person from healthcare. And again, if I think about my education, it was very much about taking the person out, about making objective decisions based on tests, you know, and listening and understanding and reasoning were less important. It was about finding the problem. It was about, you know, the right tests and then doing, you know, whatever to try and fix that problem. It never really talked about the person, the effect on that person's life, you know, their emotional state, their thoughts, their feelings and things like this. And actually, the more we understand about the problem of pain, it becomes less about the sensation and how it feels. And maybe it becomes more about how that person feels, how they behave, how they respond, what they do, how it affects their lives. So for me, the biopsychosocial model fundamentally is about rehumanizing healthcare. It's bringing that person back into what we are trying to do. Because it's not about pain, it's not about disability, it's about all of those things and the effect on this person and their existence. All right, so why do we need it is a question. So let's look at some research, some qualitative research that came out last year, potentially maybe the year before, with this whole corona thing. I have no idea where I am, who I am, what year it is. So I'm just guessing about what it was. So I think it was 2019. So this is some qualitative research into hip pain. And the title of it is My Hip is Damaged. And what they did is they wanted to go in and talk to people with hip pain and understand how they understood and how they perceived their problems. Now, firstly, all of the participants in this study made sense of their pain through a biomedical lens. They thought of it as being very, very pathologically specific. So they believed their hip pain and disability were due to damaged hip structures, degeneration, fissures, tears, detachment, and or arthritis. And let's not discount these problems from the problem of hip pain. But let's not say that hip pain is defined by these problems either. And I think that's the point of this research, is that people were very much of the perception that, you know, they needed to find the problem and fix it and everything would be okay. But unfortunately, with lots of persistent pain situations, that's not the problem, is it? It's not just the problem of pathology. It might also be the problem of living. So where did participants get these ideas about their pain from? Well, where do lots of people get their ideas about their problems from? They get them from healthcare professionals, because healthcare professionals are the people who are fundamentally engaged and involved with people with painful problems. And what we tell people and how we help people make sense of their problem will directly relate to how they behave and how they act. Now, that's the point of rehumanizing healthcare, is to understand the information that we give people isn't neutral. It isn't inert. It has a huge effect on the way they think and the way they behave. And that's what we need to consider, how the human responds and the human behaves. All right. So this was some work by Jenny Setchell and her team, and it looked at persistent back pain this time. Again, it was some more qualitative research, and individuals discussed their persistent lower back pain as due to the body being like a broken machine. Their perception of their problem was their body was a broken machine, and in some way it just needed to be fixed. They needed to find the right tool or the right, mechanic to be able to fix their problem. But again, this focuses on the problem of the back or the problem of the pain, not of the human experiencing it. So they found that most people adhered to traditional biomedical perspectives of anatomical biomechanical causes. Now, again, let's not discount biomechanics or anatomy, but let's see it as an incomplete perspective on pain, and that every lower back pain, even if it was a broken machine, is still attached to a bigger human machine that thinks and feels and is and has behaviors according to that pain. So again, the biopsychosocial model for me is not just about finding out what's driving someone's pain across many different areas or domains. It's understanding that there is a person in the middle of it. And sometimes we think that, You know, it gets discussed that there's this pendulum and it's swung from this, you know, biological place over to this psychosocial place, and we're forgetting the biological. And I always think the next time I have a patient come into me and explain their problem through a biopsychosocial lens, then I'll believe the pendulum has swung. But for now, I don't think it has gone very far at all. And why do I think that? Because the qualitative research into patients' belief around their pain is still very, very biomedical. People that I speak to, their problems are still very biomedical. Now, there shouldn't be a pendulum when it comes to the biopsychosocial model, because it's not separate. So the pendulum couldn't swing anywhere anyway. So the whole idea of a swinging pendulum, frankly, is a load of crap. But even if there was one, it's not swinging very far, let's be honest. And when you guys get to go out into the world and treat people, you'll find that actually the majority of your time is spent unpicking what other people have told people. That's the majority of what I do on a daily basis, is talk to people about some of the things they've been told by other healthcare professionals. But at this moment in time, I still feel that we've misinterpreted the biopsychosocial model, that it's not about other ways to explain pain. It's about better ways to appreciate the person.
Sorry, Cor, but maybe an explanation of the word pendulum. I think maybe some people don't know what the word means.
A pendulum is like a swinging thing. How would you explain it, Joost?
Yeah, it's in Dutch it will be a klepel. It's something when you have in a clock which swings from the left to the right, and that's constantly. There's not just one position that it is.
Yes.
Yeah. Does it make sense, Vincent?
Sure, yeah.
Yeah, great. Good for you from asking. Yes.
So, how Wijchen said 2009, the center of interest in the biopsychosocial model is not the disease, but a sick individual. And I really like that. You know, and a lot of the work done in this area is related to medical doctors, but I don't think that reduces its, validity for use in any healthcare situation. We could swap the word disease for pathology, or swap the word disease for pain. So it's not always just about pain, but about the person experiencing it. And I really like this view of the biopsychosocial model. The way we can view it not as a way to diagnose people in a different way or find the driver of their pain, but more as a philosophical model of care, a way in which we can reconcile with ourselves how we want to treat other people, how we want to be engaged in our job. And I think this is what some clinicians lack, is direction and philosophy about who they are and how they want to be versus other people. So I would say anyone here now, a great question to ask yourself is, what is your personal philosophy as a physio or any kind of clinician? How do you want to act? How do you want to treat people? How would you want to be treated? And I think when we ask ourselves that question, then we can start to think about how we work with other people. Because essentially that is the nature of working with people in pain, that it is about people. It's not about simply pathology. Now, it should never be a question of person or pathology. It's about a person experiencing a pathology or a pain or a problem, all right? So I really like this quote from Engel. Thus, clinical study begins at the person level and takes place within a two-person system, the doctor-patient relationship. So everything you do clinically doesn't exist in a vacuum. It exists in relation to someone else. And that should be one of the things that is always driving everything that we say and our clinical decision making. Not just what we say, but also how might someone else perceive that? How might it influence them? And I think that that is a key step into taking a more person-centered focus. And if we look at Engel's original perspective of the biopsychosocial model, you realize he never broke it into these three domains. We never had bio, psycho, and social. Instead, he had a hierarchy. And actually, it's really interesting, this hierarchy, because it has the person and their experiences and their behaviors And then above that, it has the two-person relationship, the family relationship, the community relationship, right up to the very top. And I actually believe that things like back pain aren't a problem of just pain. There are actually societal problems of misinformation and belief structures that drive actions and drive behaviors. And that kind of fits in with this greater hierarchical perspective. Now, some people have argued against a hierarchical perspective. And again, that could be a very valid discussion, that things lie much more on a flat level, that, you know, there isn't specifically always a hierarchy. But one of the things I think we have done when it comes to pain is we've tended to not go up. We've tended to go down. We tend to discuss the nervous system. We tend to discuss nociceptors and nerves and sodium channels and, you know, all these other kind of really, really fancy biological minutiae that are very important. But we don't always discuss some of the wider perspectives of a human being embedded and engaged in the world and the society around them. And I actually, maybe this is slightly out there, and I can be a bit of an out there kind of character, but maybe in some ways our biology hasn't kept pace with our psychology and our social, and that the social and the psychological worlds have moved on dramatically, whereas our biology has stayed really quite similar. And maybe there's now a bit of a mismatch there. Maybe that's part of the problem of persistent pain. Maybe I'm just talking crap. I don't know. All right. But please don't see the biopsychosocial model from a biomedical perspective. It's not just another way to find a pain driver. Your pain isn't caused by pathology. It's caused by your depression. Or your pain isn't driven by your Achilles tendon. It's because you're anxious. Because that's a really, really poor, misguided perception of what the biopsychosocial model was meant to be about. Let's go back to that word, the philosophical model of care. It's not a simple cause and effect explanation of linear causality, all right? And causation sometimes is a needle in a haystack. We get so obsessed by what has caused this problem. And in fact, what may maintain a painful problem may not be what's caused it in the first place, right? So causation can be elusive, and maybe it doesn't add always to the clinical encounter. But what does add to the clinical encounter is showing that you are about the person in front of you. So let's not see the biopsychosocial model through that biomedical lens. All right. So that if you take anything from today, then hopefully that can be it. And if we look here, this is kind of a more modern iteration of the biopsychosocial, and that we've split these things up. And what do we see? They are driving pain. And what does it kind of tell us? If we fix one of these things, then pain will go away. How many patients do you think have wanted to find that one thing that will fix their pain? And they search remorselessly for it. And often it's quite a fruitless search for many people, or many people that I've spoken to. I'm sure there are other practitioners, clinicians who are better than me who can find it and fix it. You know, maybe I've been unlucky, I don't know. But certainly a lot of the patients that I've seen, they're searching for this one thing that's going to take their pain away. And sometimes do we need to reconceptualize the problem, not just as a problem of pain, but a problem of a person and a problem of living as well. So we have to remember these things are bi-directional, that pain not only is affected by all of these things, it affects all of these things. And actually the reason why people seek care isn't always their pain or just their pain. It's actually the pain's effect on life, on existence, on functioning, on behavior, on how they feel. And that is a different perspective. So we need to see it as much more interconnected. We must see it as something that's complex. And sometimes it's helping patients redefine simplistic models or simplistic perceptions that can be really, really valuable to doing this. All right. So this is a really, really great paper that came out way back in 2004 when I was young and enthusiastic and had the world in front of me rather than being old and haggard like I am in front of you. I needed to get softer light. I need to get like a soft focus so that I just gently glow. So this is a really great paper looking at the biopsychosocial model 25 years later, principles, practice, and scientific inquiry. And what I really like about this paper is it puts the focus back on the clinician, not the patient. So if we look at biopsychosocial orientated clinical practice, firstly, it's about self-awareness. Who are you? How are you behaving? What are you doing? That's not what is this happening in front of me to my patient. Who am I? What am I doing? Cultivating trust. And if there's one thing that I've learned in the last 20 years, is that all of the problems that people often encounter, my patient doesn't listen to me, my patient won't do their exercises, my patient, you know, is moody, is miserable, all of these different things, I think probably have a lot to stem from relationship and trust. And people always say, why won't my patient do my exercises? How can I make them do them better? And I always say, well, probably build a bit more trust and relationship, and this person will have more engagement. Why is it any different to anywhere else in life? Self-calibration. So working on ourselves and our own clinical reasoning. Empathetic curiosity about the patient as a person. And I had a wonderful discussion actually this morning about goal setting with someone. And what we decided was that actually goal setting isn't about goals. It's about showing you're interested. It's about cultivating trust and relationship. It's not about the end result of having a goal to measure. It's about a process to build upon. Educating the emotions so that we are happy to deal with, you know, uncertainty and these type of things. Using our intuition sometimes. Communicating clinical evidence, not just the mechanical application of a protocol. And this is such a different view of the biopsychosocial model. And do you know why it's probably not popular? Because it asks a lot of the clinician, right? It's not just finding a driver to fix. It doesn't fit into the biomedical model, all right? So does your perception of the biopsychosocial fit into the biomedical? And this is a paper that is in review at the moment from myself, Peter Stilwell and Joe Gibson. And this is a model of how we think in clinical practice, we should start to use the biopsychosocial model. It starts with relationship. It can go to causation because people require causation as an explanation. It involves sense making. How does this person and myself make sense of their problem? It's about behavior change driven by shared decisions. And finally, it's about the promotion of self-management. So if you were to ask me, Ben, how do I put the biopsychosocial model into clinical practice? This is what I would tell you. And what does it start with? What is it built upon? What is it predicated by? It's the relationships that we build. It's the humanization of the healthcare contact. Now, because I'm not very good at massage, I'm terrible at most interventions, and I'm probably not very good at special tests, I've always had to rely on relationship, all right? That's the only thing that I've ever been any good at. So this is probably why I've gone towards this type of model. But this is where I believe we should be operating as human-centered healthcare practitioners. So let's look at the evolution of that, because I think from that biopsychosocial arena, it's evolved into this idea of patient-centered care. And we could call it patient or we could call it person, all right? So my aim in life is to one day to have a chair like this and to look out gently over the vista in front of me and just think and ponder on life. But maybe I'll have to wait till I'm a little older. But William Osler said very many years ago, way back in the 19th century, the good physician treats the disease, the great physician treats the patient who has the disease. And again, it's taking the onus away from the disease. And if you imagine, Engel has talked about this in the 1970s. This dude was talking about it in the 1870s, right? So these are not new ideas, but they're still not adopted, which is important to understand. But I think you guys are getting the exposure now to truly adopt this as a way forward. Because before it's been about adding on to clinical practice. Now with the things that Joost is doing like this, it is becoming clinical practice, which is a really, really powerful thing. And you guys should be really proud of what you're involved in and what you have the potential to become, you know, rather than having to add it on after you've learned everything else. So Colin McWhinney, I think he was a Scotsman. He describes person-centered care as the physician trying to enter the patient's world, to see the illness through the eyes of the patient. So you should always try and appreciate the eyes of the patient. And what I mean by that is that if you give someone an exercise to do, if you wore their shoes, if you spent a day in their lives, would you be able to do it given their circumstances and situation? Are you just giving an exercise, or are you actually thinking about the implementation of that exercise for this person? If I'm a single mother with 3 children and a full-time job, and you gave her an 8-hour exercise program to do daily, that's not person-centered care. That's clinician-centered care. So, Stuart, way back in the 90s, and I love the 90s. The 90s were the best era ever. All right, you had Oasis and you had Blur. Anyway, I'm not going to go into the 90s. The 90s were the best. Never let anyone tell you the 90s were not the best. But Stuart described it as a willingness to become involved in the full range of difficulties patients bring to their doctors, and not just their biomedical problems. And this is some work by John Lucer. John Lucer, kind of in the days of people like Gordon Waddell, etc. These were real pioneers. I'm just regurgitating. These were the real pioneers of healthcare. But understanding that we have layers to what we call this pain experience, from nociception to pain. These are the things we talk about. Nociception doesn't equal pain, etc. I've heard that a million times. But what about the suffering? What about the pain behavior? And in essence, actually, we can never assess pain. We can only ever assess pain behavior, which is something that's quite fascinating. Bellin called it two-person medicine. So leaving today, how do you describe your clinical practice? Is it one-person medicine or is it two-person medicine? All right. And I think that fundamentally is a really nice view and way to perceive it. Because I think a lot of the things that we complain about and we moan about and our patients don't do this is because we are practicing one-person medicine, not two-person medicine. And once we start to practice two-person medicine and the relationship that involves, I think we're going to go much, much further to being more successful in the ways that we want to be successful. So this was from Melin 2019. Person-centeredness implies an ethical consciousness about the patient as a capable person, who he or she is, rather than what health problems he or she has. All right, so we can see that these are really quite consistent through from the 18th century, the 19th century, the 20th century, the 21st century, that we are seeing a shift in how we're understanding healthcare. Unfortunately, that shift is not being adopted. And one of the reasons I believe it's not being adopted is because it's too much effort. It's too much hard work sometimes. And again, it comes back to the clinician to say, how do I want to do this job? Who do I want to be? What do I see this job as being? Now, some people see it in a caring, relationship-centered way. Other people more as technicians, that they're solving the problem and they're fixing it. Although sometimes the problem isn't one to solve. It isn't just finding another thing somewhere. It's actually the problem is of the person who is suffering it. All right. So I really like this from my good friend Gilletta. And I think Gilletta is coming to speak to you guys maybe tomorrow. And Giletta's been one of my friends for many years now, from my journeys and my presentations at things like the San Diego Pain Summit. And we've got to have some beers and got to have some drinks. And that's always the best way to get to know people. Not coffee. Coffee's bad for you. Alcohol is the source of life.
Definitely, Ben. Just Giletta's coming tonight. Tonight at 7
she's
o'clock.
Coming tonight.
7 o'clock European time, 6 o'clock UK time. Gilletta is on the air. So sorry to interrupt.
No problem. So Giletta's in Colorado.
Yes, she normally is. She's at the moment. She's in San Diego. She's along the Californian coast. So she's even further west. Yeah.
Not that she being on the Californian coast makes me feel sick, because it does a little.
No.
Right? Do you know the things that you don't want to hear?
No.
Right.
Right. Yeah.
So, I asked Gilletta, I did a presentation at the San Diego Pain Summit in 2020. And I asked Gilletta her perception of person-centered care, because it's very good asking clinicians what their perception is. But at the end of the day, person-centered care should really be defined by people experiencing it, right? So I asked Gilletta, and she described it as people with pain and clinicians having conversations. And again, I don't like the idea of clinical history taking or subjective assessment. It really should be a clinical conversation. Because if you imagine a clinical conversation, what emerges from it, that it gives us an opportunity to talk in different ways and get different information rather than yes, no, 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 yes, no, no, right? It's actually an emergent conversation that gives us information. So she described it as people with pain and clinicians having conversations that help make sense of what is happening and lead to the discovery of a possible path forward. So it's moving away from this idea of explaining someone's situation towards helping people make sense of it. Because I could explain it and the other party doesn't understand it or it doesn't make sense to them. So it's about explanation, interpretation, and understanding, not just simply educating. So I hate the word educating. What does it mean? It's like a teacher going, your pain is, which is crap. Right? Who wants to sit there being lectured and taught? We are here to help people make sense of their problem. That's the key. It's not about how well I explain it. It's about how well it's interpreted. All right. So she goes on to say this, which I really like. A story that makes both biological and biographical sense. So it's in the context of that person's story. So that for me is the magic of good clinical explanation and good clinical sense making, is that it takes the person's story and it takes our understanding of the problem and it merges them together. So person-centered care is not about replacing the person in pain's story with a clinical story or a medical story or a scientific story, which is often what happens. And this is why I believe things like explaining pain haven't worked as well as we assumed they would, because it's just another scientific, biological lesson that people probably don't care that much about, because how does it relate to them and their problem? And I describe it like being with a drunk in a bar and they're telling you their life story. And frankly, you don't care because it's got nothing to do with you. It's boring. It's, so information, it should be given within context. And I think that's how Gilletta's really nicely framed that there. And this is a paper back from 2008. Looking at, again, qualitative literature is really fantastic. Looking at this idea of partnership for people seeking care. And what do they want? What do they want from their clinician? So they want effective communication. In fact, some communication is always good. They want dialogue, which means that they want to be able to communicate back to you. They want space to be able to speak. They want validation of their experience. And one of the big lessons I've learned is that sometimes just taking a moment to say, that sounds really tough, or I can imagine why having to see 30 physios is really frustrating. That can be an absolute game changer for some people because it shows you care. It shows you give a shit. And that's what often people are looking for. They want their values to be considered. They want clear technical explanations. Again, an explanation that probably relates to them, not just medical jargon or biology. They want you to be able to manage diagnostic uncertainty, which is a real skill within itself. They want their individual goals to be considered, not just how much range of movement or how much quad strength or, any of these other clinical measures that we take. And they want things like their personal level, fitness levels and experiences and preferences to be taken into account. These are things that people want. And these are probably things that we can deliver if we are taking a different perception and focus to our clinical work. So what's my perception of person-centered care? Well, firstly, it's about listening, but not just listening, showing people you're listening. because that shows you are engaged, all right? And it's a bit of a buzzword, listen to your patient. You know, so I think that we should explore that concept a little bit more and what it really means. It's about validating people's experiences. It's about creating and cultivating collection and alliance. It's about helping define the values and goals and expectations of what the patients have, because actually that's what drives things like intrinsic motivation. And when intrinsic motivation drops, we know that that's a big problem. So we know expectations are a really large prognostic factor in musculoskeletal medicine. It's about being able to communicate best clinical evidence. It's about appreciating the barriers that people have. It's about shared decision making. It's about helping people plan. Again, another tip from me. If a patient leaves your encounter without a solid, realistic plan, nothing will happen. People don't just need big messages about exercise more. They need ways that they can engage. They need plans to engage with it. And that we miss that basic human need. And my example is, imagine if you went to IKEA and you bought a chair from IKEA and you got this IKEA chair home and you opened the box and there were no instructions in the box. You'd look at it and you'd be like, oh man, this is a bad day for me. You would close the box and you would stick it under the other chair you've been using, right? Because, you know, because we need direction and instructions for things we are not good at, right? Or things we have low self-efficacy around. So it's not just about telling people to go and exercise. It's about giving them a realistic plan to do so. That's person-centered care. It's about helping people to navigate their social resource, and it's about identifying and providing a support network for patients. Now, you can read this and say, Ben, that's bollocks. I don't believe that that is person-centered care. And I will say, absolutely, this is my perception. This is my belief in what it means. This is my personal philosophy. But I think there's some good data in there to suggest that these things are relevant to modern musculoskeletal practice. So, you know, let's think about even just key questions we could ask people. What's the most important thing you want me to help you with today? You know, putting the focus on what information do you want? That's a real key, showing that you are interested in something that this person is interested in. And we talk about reassurance as a modern, you know, rehab tool or technique. But how can you reassure if you don't know what to reassure about? So again, a really simple question is, you know, what is concerning you? What would you like to know more about today? All right. So don't just think that reassurance is automatic. What are you reassuring about? Finding out is probably a real key. All right. So we've looked at a bit at the biopsychosocial model. We've looked a bit at person-centered care. So let's think a little bit about how we then think about this in terms of the more empirical, the positivist, the Humean perspective of evidence-based medicine, you know, the objective way that we should treat. And this is the real tension, isn't it? It's bringing these concepts together with this idea of evidence and what works and what you should do as an evidence-based clinician. And that involves knowing more about what we've talked about. But I think it also involves understanding a little bit more about the philosophy of evidence. And I don't know if Joost has had Roger Kerry. And that's one of the things that I really enjoy that Roger speaks about, which is this understanding fundamentally what should drive evidence-based medicine. Again, is it just about numbers or is it about people? Or is it about the combination of the two? And that's the tension, isn't it? So let's talk a little bit about evidence-based medicine. Now, look, I'm just a clinician. I'm not a statistician. I'm not a researcher. So, you know, other people may give you a completely different perspective. But I think what we lack in our modern perspective around evidence-based medicine is how we integrate that into clinical practice. You know, that it is about how you as a clinician use it, not a researcher, not a statistician. You are the end user, or we could say your patient is the end user. And that's the perspective we also need. And again, this isn't my major focus or drive. There are other people doing much better stuff in this space. but I still think it's part of what we are trying to talk about. So evidence-based medicine, what is it all about? Evidence-based medicine should really reduce poor practice by integrating good evidence, that we do need a way to break down the clinical story that I was told by, you know, my friend or my colleague who's been practicing since 1870. You know, we need a way of kind of saying, you know, things change and there's different information and evidence. So evidence-based medicine is really important for updating practice, for you know, testing out questions that we have. So what is it? This is from Sackett, and it was Sackett and Guyette, you know, way back in the 80s and the 90s who started to talk about this. It's the conscientious, explicit and judicious use of current best evidence in making the decisions about the care of individual patients. And what we tend to do sometimes is we don't use it judiciously, and we don't use it in a conscientious way. We can use it as a bit of a blunt tool. And I think that we can do better than that. But firstly, we have to understand what is it and what is making it up and what the tools are. So I really like this quote. People use statistics as a drunk uses the lamppost, for support rather than illumination, right? So how are you using evidence-based medicine? Is it to justify your bias, your treatment, or is it actually to help a patient via best evidence? And I think that's something that we do need to ask ourselves. And I witnessed people arguing about interventions. Exercise is best. Manual therapy is best. I've got this abstract from PubMed that tells me it's best. And actually, I think that's a really, really crappy way to use evidence-based medicine. It's about justification, not illumination. So, you know, if I'm going to be a drunk, I'm not going to lean on that lamppost. I'm just going to lie on my sofa and go to sleep. And I really like this, and this was from a paper that Roger wrote, but it's a quote by Sarovitz. And researchers seek to reduce bias through tightly controlled experimental investigations. In doing so, however, they are also moving further away from the real-world complexity in which scientific results must be applied to solve problems. So remember, it's part of our tool. It's part of our toolbox. But research doesn't simply reflect the real world. In fact, it doesn't reflect the real world, because that's the point. You are controlling every variable, or attempting to, whereas the real world attempts to screw you at every opportunity by introducing as many variables as possible, right? So there's a real difference there. But we cannot consider population level research evidence to directly relate to the patient in front of us. So fundamentally, we need to appreciate what evidence is. It's tightly controlled, population level average data, which is hugely informative, but it doesn't always tell me what to do exactly right now for my patient. All right, and that in some ways is the way that the internal workings work. You know, how people research things. We have this wonderful way of asking yes or no questions. A hypothesis or a null hypothesis. Does it work? Have I reached 0.05? And what's the difference between 0.05 and 0.06? I don't know, right? But fundamentally, I think we need to move away from the idea that evidence simply tells us based on a threshold of yes or no, right or wrong. And we need to change how we perceive evidence as much as we need to change how we perceive the medical model that we use. All right. So Sander Greenland is a really, forward-thinking statistician. You know, if you ever get to read some Sander Greenland stuff, it's always worth having a read of. So we use things like these null hypothesis tests to try and provide a link between our practice and our evidence. But it's so binary that it doesn't take into account the messy nature of what we're trying to do. And the ways that we do that through things like alpha levels, p-values, hypothesis testing, don't really reflect the heterogeneity of what's actually gone into the whole process. You know, it's a p-value is only dependent on the test or the experiment that it relies on. So what does the test or the experiment look like? Not what does the p-value look like? And again, that helps us start to understand that it's not quite as simply cut and dried as sometimes the world of evidence-based medicine tells us. But I am a huge advocate of evidence-based medicine, but I'm also a huge advocate of using it in the proper way. So we should move away from this idea that things are simply significant or not significant, that it's just a yes or a no, it works or it doesn't work, because I don't think that reflects a wide range of responses that our patients give us. And actually, if you think about outcome measures, you know, we focus in on one or two outcome measures that, you know, sometimes are very, very difficult to quantify objectively and don't always give us the information that we require. And this is from Neil O'Connell. He says, it's clear that the mean between group difference is a somewhat blunt tool with limitations. It tells us little about the individual experience of participants in clinical trials or the factors that drive them. So be aware of the values and the limitations of evidence-based medicine, because when you come out into the world that I inhabit, it seems that it just boils down to, does this work or does it not work? Which I always think is a really, really rubbish way to view evidence in clinical practice. This line in the sand where we say yes or no. And maybe we need to be moving more towards an understanding. It's not just about whether it is significant, but how significant is it? How significant is the difference that we see between two groups? Does that matter more to me clinically? So my wife has always told me that size doesn't matter. She's very, very generous to me like that, right? But this is definitely a situation where size does seem to matter. And that's when it's actually a size of an effect of an intervention, not just whether it has an effect, but how much of an effect does it have? So a question that you need to ask when you read evidence is not just, is it significant, but how significant? And how might my patient fit into that significance? So taking a person-centered approach to evidence-based medicine as well. So this is really great. I really like this from Jean Glass. Statistical significance is the least interesting thing about the results. You should describe the results in terms of measures of magnitude, not just does a treatment affect people, but how much does it affect them, all right? And even then, if you look at individual data, if you look at confidence intervals around average numbers, you actually realize this is way more variable than perhaps we originally considered. So let's think about this. I'm just going to check the time. Oh, I'm not too bad on the time front. Putting EBM and PCC into practice, all right? So the question we have to ask ourselves is the patient's story evidence? Some people would say, no, it's uncontrolled. It's full of bias. Oh my God, you cannot use that. Whereas I would say the biggest piece of evidence we have is the patient's story, right? We have to reconcile that with other evidence. That's the key here. Not just, it's bias. Oh my God, it's uncontrolled. A person's story will always be the primacy here, I think. And nothing that they ever tell us is provable or unprovable, right? How do you prove it? You can't. It's in the same way if someone tells you they have 10 out of 10 pain, they have 10 out of 10 pain. What else can you say? No, you don't. You can't say that. You can't prove that. You have no evidence. And even to think like that is sometimes, I don't know, it's not a person-centered approach. So thinking about how does this person fit into this randomized control trial? Well, this is individual versus population level data. They are not the same thing. Different days might produce different responses. One thing you'll learn about pain is just unpredictable. And some days it's amazing and some days it's terrible. And we don't know why. Is that reflected in the 6th month follow-up that was recorded on? I don't know. Different environments, different contexts, we might have different responses too. So population data and individual data are not one and the same thing. Even if you feel one is uncontrolled and one is controlled, they're still not the same thing. This is a great piece of research that looked at individual outcomes from exercise. A guy called Hendrickx out in Denmark looking at plantar fasciopathy. And here we can see individual responses to, or individual outcomes, because responses maybe isn't the right terminology. What we see here is that two people with the same level of pain responded completely differently to the same intervention. And none of these people, one person seemed to respond similarly to the mean intervention, to the mean data number. So individual responses are not the same as mean numbers. This is what we deal with clinically. Look, let's take this patient here. 10 out of 10, 100 out of 100 pain, down to 0 out of 100 pain. You would have got a cake or a beer or some wine. It would have been the best clinical day ever, right? Whereas some other people, let's take this person here, look at how much the intervention made their pain increase, right? So what happens in the middle isn't always reflective of what happens to your patient. And that's how we need to think a little bit more about evidence-based medicine. That population data is important, but individual clinical data is also important as well. So the tension is real. And this is some work by Robert Weaver. Some suggest that EBM is at odds with another parallel movement towards care that is patient-centered that has arisen. So we see these tensions, and that's the point of what I'm trying to discuss. And our job is to reduce those tensions and understand where they exist and why they exist and what the relationship between them are. And, you know, I think that we have to think about integrating evidence into practice, but not always having evidence as the primacy behind our decision making, because it makes us sterile, it makes us cold, it dehumanizes healthcare. And I think that rehumanizing healthcare isn't not using evidence, it's using it appropriately, understanding what it is. And it comes back to exactly what Sackett said, that it's about the judicious and conscientious use of evidence, not using it as something to prop us up. Now, again, even within evidence-based medicine, there are different philosophies. People have different leanings. You know, some people are like, evidence, you know, is a tiny part of what we do. Other people are like, evidence is everything that we do. And you have to decide your own philosophy. But you have to start with understanding what it is to begin with and what makes it up. So rather than giving primacy to knowledge derived from research, the patient-centered care paradigm operates within a humanistic framework that considers what emerges from clinical interaction. So if you're going to take one lesson from today, and maybe you won't even take one, I have no idea, is that it's not about me, it's not about my patient, it's not about research, it's not about evidence, it's about all of these things mixing and interacting. And what happens is emergent, it's not definable simply, it's not always quantifiable either. And I think that we have to understand human beings are messy, they're contradictory, they're all of the worst and the best things that we can ever understand. And that's what we work with. And if we can reconcile that with ourselves and be comfortable with that and not always have to have all the answers, you know, I think we're going to be good clinicians. Thank you.
Wonderful, Ben.
How did I do for time? Oh, that is amazing. Look at that.
You really, well, this is a new record. You just finished completely in 1 hour. So this was really amazing. This is nice, isn't it? For all the people?
Well, I hope so. Look, you know, sometimes we like things very ordered and structured and do this and then you are patient-centered care. But in reality, it's not. It's messy, it's ugly, it's about being adaptable, it's about being variable, it's about being a human. Human, person-centered practice is about understanding we're all humans and we all mess it up and we all do brilliantly. And sometimes we're happy and sometimes we're down and sometimes we're, you know, ambivalent. And, you know, it's managing and dealing with that on a daily basis.
Yeah, definitely. And this is always the nice thing around that it is the ambiguity between the people, between the things, thoughts, the different perspectives, and you have to mess it up. And at the same time, everything that you knew is changing directly, I would say. So it's a complexity and it's interactive or interactive, depends on how you look upon it. Mm-hmm. My biggest question right now, because we are here with a whole group, and we know there's some questions we got already in the chat. But for those of you who are present, what are there some parts that you think, well, this is something that really struck me, or this is something I really like to dive a little bit deeper into it? So, for example, I see now Siem, Danique, Carlijn. Those are the first ones. Sorry. Yeah, it's all, isn't it, Ben? That's always the ones that you see. That's the ones you're going to ask questions to. That's also.
Yeah, sitting at the front of the class.
Yeah, that's how it is. Don't worry. But I would just ask, is it something that you just crossed your mind right here?
Yeah, something really interested me. There was the table that you showed that you said we tend to go to, so even more difficult biomedical explanations, and you maybe opted that we should need to go give more explanations about society or cultures. That's something really interested me.
Yeah, it's not just about explanation. It's also about understanding. So back pain. Let's take, for example, I think you're talking about the George Engel, the hierarchy, right? Yeah. So someone comes to you with back pain and they give you some kind of explanation that they've heard, right? So I think sometimes as clinicians, we have that righting reflex. It's like, no, that's not right. This is how back pain happens. And I think understanding that these things aren't just about this person. Where have they got this information from? Why is this such a deeply held belief? Why does it affect their interaction and their life? It is because these things aren't just sat in people's brains. They're embedded in society. So our perception of the problem sometimes is too narrow. That actually these are problems of, you could say back pain is an infodemic. Isn't it? It's a problem of misinformation sometimes, that people that, slip discs and, various different things. So I think that we have to consider, where people get information from, why they want certain treatments. It's not just down to them. This is a massive societal thing. And if we appreciate it only at an individual level and look to correct the person and put them on the right track, we misinterpret the size of the problem.
Makes sense, Vincent?
Sure, yeah, really interesting. It's something I want to dive deeper into. Just give the explanation of how the society contributes to, to every individual case.
Yeah.
Yeah, well, I mean, it could be as simple as, it could be, if you think about this, people pick information up from their families. They pick it up from television. They read about interventions for back pain in magazines or newspapers. They hear about why this has happened, medically on the news.
Or advertisements for all kinds of treatments.
And now we wonder why patients don't suddenly change their beliefs when they come in and you give them a little bit of information. Because you are a drop in the ocean of other information. So don't get a big lesson, I think, is don't get frustrated because you can't change someone's mind in 5 minutes. Because you have to understand the problem first.
Okay. In between, we had some questions also in the chat, and Maria put some questions there. Maria, maybe you want to ask them.
Yes, thank you. I started to follow on YouTube, but then it was so interesting. I had to ask Joost to get in here. So thank you so much for a wonderful talk. I come from Bergen, the HVL, and we will for sure invite you to come to us to talk more. I was just thinking that it was several things I was thinking, but I very much agree with you. And I was thinking of what you said about research and giving very much attention to the p-values. Because I've also been working as...
Sorry, Maria, your sound is a little bit... Marie? Does the rest hear the same thing?
Yes,
so I
couldn't hear.
That we couldn't hear you.
Yeah, I could see that you didn't hear me, actually.
Yeah, it's not... You could write... Do you want to write the question?
I have written it in the... I think you understand my question, actually. Or my comment.
I will do. And then, Maria, do you have your earphones with you? close, maybe that's helping as well. The question of, well, there's a lot of questions here. The question of Maria. So it was, thank you for a great talk. Is it still to distinguish between psychological factors and biological factors? Maria agrees about the strong connections you make, but can we go further and remove the boxes? Does it make sense? I will.
Yeah, I'm not sure.
No,
Sorry.
wait. I would just put it in. That makes it easier. So to get the questions.
All right, do that. Yeah. Then I can read it.
Yeah, that makes it easier. Wait, Maria, maybe you can talk around now, then it goes easier. Maria, maybe your sound is now better. No, can you try it again?
Oh.
Yeah, does it work now?
No.
Okay.
But write it, and you write it, and I'll answer.
Yeah.
So, Joost, in response to this question here, so it's really about, I suppose you could say that you really need to be can we ever distinguish between the biological and the psychological? You know, the underpinnings to some degree are biological. And I think we do need to biologize psychology to understand its impact on other systems. All right. So to have a unified system, you know, we have to understand that there's probably a biological underpinning to everything. And that, you know, maybe is a factor as well. So I think that we can identify factors. Do we need to call them biological or psychological, or can we just call them factors? You know, so if I believe someone has pain-related worry or anxiety, you know, I suppose that could affect them across the biological, the psychological, and the social spectrum, right? So it depends on how we view it, just as a causatory thing, or we're actually viewing it as an entirety as a human thing. So I still think we can pick factors out. Can we simply put them into 3 boxes? Probably not.
Does it work better now?
Yes.
Yes. Okay. Thank you. Thank you. But a good answer. And I think I agree much with it. I think it's just important not to make too hard distinguishes between. I still hear people saying body and the difference between the body and the brain, and you put also the brain under biological factors.
Well, that's what Engel was saying. He was avoiding dualism.
Mm-hmm.
That was Engel's main goal because Engel was a psychiatrist. So Engel's goal was to say, you know, there isn't a mind-body dualism, but now we've called it a triism, right? So, or what we've described as a trichotomy, that rather than have a dichotomy between body and brain, now we have a trichotomy between these other factors as well. And in reality, they just don't simply divide neatly into these things.
Great, thank you. There's another question what I got from Florian Abu Bakar about the relevance of conversation. Conversation is interactive communication. I do not see this enough as being part of Fysio's curricula, at least in the Dutch setting. But how can we finally change this? Do you have an idea?
Me?
Yeah. Just if it was up to you.
I mean, this is above my pay level. Look, change always comes from people who want change. So nothing will change in the curriculum of anything unless someone identifies it as important and makes it their work to create change. So one of the big reasons nothing much has changed clinically sometimes over the past 25 years is because sometimes the institutions don't always have the person who's driving change. So change comes from people who want change. So you need to find people who are really, really passionate about this and implement some of that change. People create change. Communication is never going to change unless someone puts an importance upon it. And I know from speaking to Joost that, you know, how he's been involved with his program, you know, what an inspiration that I find that someone who wants to create change and isn't just talking about creating it, is also implementing it. And again, it comes back to what I discussed earlier. It's not about big messages. Sometimes it's about action plans. Action plans create change, not just big ideas.
Definitely. So just go in there and start to do things.
But otherwise, again, this is a metaphor for your clinical practice. You can sit there and tell your patients to eat better, sleep better, do all these things better. Information doesn't change behavior. Action changes behavior.
Yeah, definitely. I think that's a great important part, that it's the action that drives us, but how to come to action sometimes. And it's not about sometimes about what to do, but how to do it and why.
Perfect.
Hank, you have a question, please, Hank.
Yes. I was thinking, thank you for your very interesting talk. I didn't could follow everything because I had my groups here on the hub, but I was really thinking in the Netherlands, there are many guidelines. I think we have the most physiotherapeutic guidelines in the world. How does this relate to PCC?
Yeah, it's a great question, right? So I think that guidelines are one thing. So guidelines are up here in the hierarchy. Then we have clinicians, and then we kind of have patients under here, right? So I'm not saying that's the way it should be. I'm saying that's the way that it is. Now, one of the reasons people don't adhere to guidelines or clinicians don't actually follow them, and one of the things we know is that clinicians don't follow guidelines very well, right? Why do they not follow them? Because I don't think that they always see how to apply them. So it comes exactly back to what we were just talking about. So let's take back pain. In the UK, we have our NICE guidelines, etc. I should use education and exercise for helping my patients with back pain. But what the hell does that mean? How many different ways are there to exercise? Education about what, when, how, what if it doesn't go well? So again, I think that we need to understand that guidelines are powerful because they're broad. And we also need to understand they're weak because they're broad. And what we don't do enough of is help people understand how to implement guidelines. How can they put them into practice with patients? You know, what should that look like? What should it feel like? So we're missing a step. This is the point. We need to get from guidelines that are based on best available evidence to how we can implement those clinically on a day-to-day basis. And without that step, that's where guidelines fail. So it's the same as the smoker. You know smoking's not good for you, but no one's given me a plan to stop smoking, right? You know that exercise is, bad. My smoking's bad for you, not good for you people. Don't smoke. All right, stay in school, kids, don't smoke. And also, we know that exercise is good, but not everyone exercises. And maybe that everyone shouldn't exercise, I don't know. But we are missing implementation. And I think fundamentally, we are misunderstanding the human condition, that we need to find better ways of bringing guidelines. We need to find how the guidelines look in clinical practice, not just what are the guidelines. How many ways to exercise are there, Henk?
Countless.
I thought you'd name them all. I'm disappointed in you.
Oh, yeah. Well, first, I know.
Yeah. No, so let's say there's 10,000 ways to exercise. Which one should my patient do? How much should they do of it? You know, this is where we get to. This is where the blockage is. And I think that that's what we need to do. We need to say, who is this person? What are their previous experiences? What are their injury experiences? What are their preferences? What are their capabilities? And I had a chat this morning about goal setting. Now, we decided that goal setting is very much about communication. But then equally, is goal setting a way to get to know your patient? If I understand more about them and what they want to achieve and what they want to get back to doing, it's not just about setting a goal. It's also about learning and understanding about the person in front of me. And how do I implement guidelines? Knowing more about the person in front of me, knowing more about the guidelines and closing that gap.
Right, thank you.
Thank you.
I think, Ben, in this sense, it's kind of interesting always when we talk about guidelines. And recently I've been quite a lot in touch with John Gabay and André Lemay concerning the Mindlines concept.
Yeah.
So how to move from a guideline to put it into practice.
Yes.
And also how it inflects you, and also how it goes into kind of the interaction. But I think that in this sense, also Marjo had some questions. So Marjo, please.
Well, I had a question and a remark, so I will first do the remark. Thank you, Ben, for this nice presentation. I followed it from the beginning, had some telephone in between, so must have missed something, but actually I could follow you perfectly. The first thing about implementing guidelines, this beautiful booklet, you know, of course, from Tricia Greenhalgh.
Yeah.
And she advocates to develop guidelines by using more qualitative research to contextualize them. And actually, because they don't work, I fully agree, because they are too broad and in every context different. But my question to you is, this kind of decision making is very complex, what you're talking about. And it asks a lot of knowledge and a lot of skills. How would you advise us to teach this as educators?
Yeah, I mean, look, I would take my comments with a pinch of salt, because I'm no oracle here, and you know, there's probably a lot of answers to the multifaceted area that this is. I think, you know, if you were to ask me, and this is only my opinion, I think we need to be teaching clinicians about the philosophy of evidence from the beginning. So what is important here? You know, what should we, you know, at the moment, it seems like evidence-based medicine and clinical decision-making gives primacy to this kind of empirical kind of research. So is every clinical encounter qualitative research?
Yes, well, that's very interesting.
Yeah. Do you see what I mean, though? Because you could say a criticism of qualitative research is you can't put that into an average. Every single one of these pieces of information is standalone. And you're not controlling for bias, you're asking for bias. That's the point of it.
Yeah, but although there are much modern guideline development in the Netherlands, they try to also review all the qualitative research on the subject. So there is, of course, some way of a scientific way of reflecting on qualitative research and finding similarities that provide more specific information about, in this context, this would work, in that context, that would work. So there you contextualize actually your guideline.
Yeah, of course. But I think what I would like to see is that we actually value what people are telling us more. You know, I think sometimes there is this idea that what people are telling us is a little frivolous. What we need to do is discard half of the information to get down to the hypothetico-deductive reasoning part that gives us, you know, diagnostic information, rather than the more rich tapestry of information that there is. So I think it's important that we also, when we talk about the philosophy of evidence-based medicine, we start to bring in, as I said in the presentation, is the patient's story evidence?
Yes.
And I think that's where we need to move towards.
Okay, I understand what you say.
Yeah.
I fully agree. And it is really, when I'm looking back at my practice of 35 years as a physical therapist, I'm so sorry that I didn't make notes of all these interesting stories. So actually, we should empower our students, you know, to make more reports on these beautiful stories of people.
Yeah, you know, yes, absolutely. And I think we have to do that also by trying to reduce burden as well, because I think one of the problems is modern student clinical practice is probably really, really overwhelming sometimes. But you know, if I was Joost and I was designing the physio program, I think the first two things that I would look at were evidence-based, the philosophy of evidence-based medicine and person-centered care as underpinning everything that moves forward.
Okay.
That's what I would do.
We will think about it.
I like it, yeah. I hear you. No.
Yeah. Oh, wonderful, Marjo. Yeah, we'll definitely take this one into account again. Vincent, you want to add something from a student perspective also in here?
Yeah, something what I really noticed with my peer students is that most starting clinicians have very few experience, maybe little to no to few experience, and I think most physical problems we already experienced are really easy to explain with the biomedical problem. So let's say strained hamstring or a sprained ankle. So what I noticed maybe in terms of I would call it maybe imagination, or maybe in explanation about what the biopsychosocial model can do for your clinical reasoning, I think is something that's really interesting in educational purposes. So because the biomedical is also really easy to understand and also easy to practice.
Yeah, look, 100. There is the medical model has an intrinsic allure. It appeals to us to be able to solve the problem, and it's objective and it's scientific and these type of things. But I think one of the big problems is you can never be developed until you're developed, if that makes sense. And as human beings, we develop along the whole way, don't we? And it's very, very tough to ask someone who's 21 to know everything about the world and about life. I'm 42 and I'm nowhere near knowing very much about anything. And I think that is part of the issue, is that people, I think, the best clinicians are ones who probably realize it's not the finished job yet, and maybe it will never be the finished job. But one of the things is there's no shortcut, unfortunately. And if there was a shortcut, it might mean that life was a little bit shorter as well, and we don't want that, right? So I do think it's about, appreciating and understanding that you can't be the best you're going to be when you leave, but hopefully by the end, you're going to be the best you can be.
Right, thanks. Then two topics that just come up. One is more concerning the research. That will be the last one. Or maybe we start with that one and we keep the topic of from the last bit. Maria, you start also something. Can you take this one?
Yeah, I can do it. Do you hear me now? Yeah.
Yes.
Yes. So a topic that I've enjoyed discussing a lot is research, because I have been a researcher for many years and doing my molecular stuff in small plastic boxes. And if anyone took those results out and directly translated them to a human being, I would be very disturbed, because they are only correct within this very narrow environment. So I agree very much with you, what you said. What I do think is that it's not the research that is the problem, it's how we implement it and how we understand it. As you say, taking an abstract of a paper and making it the whole big truth. So and we do it too much. I think we rely on say the p-values under 0.05. Okay, then it's true. It's 0.051. It's false. And so that is the mistake I think we're doing. So I don't think it's the research that is a problem, but it's the understanding of it.
Yeah, no, and look, so let's go back to my first week with Joost at university. I think that comes back to understanding the philosophy of evidence and what it actually means. How do we define that right at the very beginning? So look, I mean, the problem with clinicians to some degree is we want research to answer the questions that are broader than they are, right? So people say to me, Ben, does exercise work? And I'm like, for what? For who? For when? Right, which is the point. Clinicians want to know that exercise works. It's going to fix back pain. It's going to fix ankle pain. It's going to solve Brexit. It's going to fix world peace. It's going to land on the moon, all of it. But actually, research is asking small questions and giving small answers. But that's the philosophy part of evidence, isn't it? Is understanding what it does and how it operates and how it works. So I completely get that again, I think the real key here is more about collaboration. It's about clinicians understanding more about research. And I think it's about researchers asking better clinical questions. And I think when you bring those two things together, you're probably going to get better answers. But I completely think you're right. But I would say when it does come to the p-value, though, I think the whole idea of hypothesis testing and refuting, going back to Fisher and Neyman Pearson and all these guys back in the 30s, the whole idea that everything is a yes or a no question is a flawed framework. And that still does happen very, very regularly. So I think clinicians need a better understanding of what is research and what it's telling us. But then I do think we need to stop asking yes or no. Is it significant? Is it not significant?
I agree very much. If I can have one comment about the physical activity, if it works or not. I can quote a famous doctor here in Norway who said that, yes, running, it might help you and you can get some more lives on your life expectancy. The problem is that the extra time you get is the time you used for running. So you better like running.
Yeah. Which you know what that is? That's person-centered care. Do you see what I mean? It's crossing both. It's what's the pros, what's the cons, what's the cost, what's the benefits. And for me, if it comes to exercise, I don't even think we have to enjoy exercise. I don't think that matters. But I do think we have to value the benefits. And I think that's the key, is moving from people this idea that you actually enjoy it, but do you value the benefits that it gives you? And I think that's maybe a different perspective.
Yeah, or maybe the same. Well, yeah.
They might be the same, but they might not be.
Thank you.
Thank you. Then we come to the final question, which was from Jesse. Jesse wrote, thank you for this insightful presentation. What about patients that don't want you to dig deeper and just want you to fix your problem by some manual interventions or exercise?
Okay, that's cool. Again, I think that comes back to what I described beginning about cultivating trust. Again, these problems that we find, we've named all of those problems just there. And I often think, why? Look, let's say Joost, you've come to see me. You've got some kind of problem. We won't go into what that problem is. Who knows? Why, and we talk a little bit and we communicate. You've just met me. You may not feel that any of these things are relevant to the problem you have. So why are you going to communicate with me about all of these things? And, firstly, you don't know me. Secondly, you don't see the relevance to your problem. We can't expect people just to pour out everything ever about everything. It's about, these things take time. They take trust and cultivation, and actually they may never happen. So I think this is the problem. We have this expectation of this really, really simple model of the biopsychosocial, whereas actually it's ugly and it's messy and it may actually never happen. And actually you could say that it ruins a therapeutic alliance by digging deeper. Sometimes you have to know when to slip in the odd question rather than go in like an amateur psychologist, right? I think that's the key. So again, but what is the key to that? I think the key is if they don't want you to dig deeper, don't dig deeper. But there's often a time and a place where people do trust and they are willing to go deeper. You just need to pick that appropriate time.
Great, thank you.
We have a question.
Yes, please do.
Like, how would you deal with patients who expect you to know the answer on their problem, that you cannot immediately provide that answer?
Yeah, so I mean, you're talking about managing uncertainty, really. Being able to manage complexity and uncertainty to some degree, because patients want like non-specific lower back pain is a great example. Patients come in, they want the answer to that problem, and they want me to know exactly what to do next. But unfortunately, the majority of back pain, we can't be definitive. So I think it's, again, trust, relationship, they probably relate really well in this area. But, and in fact, I don't know if you've seen some of this research by Michel, Michel, which is about managing complex medical uncertainty. I think she was a nurse. And, I think what we have to be able, and Firstly, if I was you, I would practice trying to manage uncertainty. What I tend to do in these situations is I can't give a definitive answer, but I could probably give you various options about why this could have occurred. So I think rather than say we give a singular definitive one, maybe we give 3 or 4 different options with the idea that it could be any one of these things, but essentially that might not change the outcome, which is what we might know about non-specific back pain. That it could be a number of different things, but all of these different things seem to act in quite similar ways in the first period. So managing uncertainty and complexity is the hardest thing to do in healthcare. And there isn't just an answer that I can give you. That would be disingenuous of me. But I do think giving options is often a really nice way to start.
Thank you. I think that also was a nice question, Danique, and from the
brilliant.
whole, and also a nice answer, Ben. And I think that also drives also a little bit back with Roger, what you talked about with Roger Carey concerning dispositionalism and the NS1 and how does it work with complexity. So for all of you, we are a little bit fortunate that we will talk tomorrow. We have the chance to have this kind of talk also with Roger and with Rani to dive a little bit deeper. But I think that what
they're much smarter than I'll ever be.
Well, I don't know. Let's see if they have create the same fun, Ben. That's also kind of a you put the bar quite high right now.
I'd rely on charisma, not intelligence.
Great. Then looking at time, I want to say a huge thank you, Ben, for spending your time and helping us out with this kind of conversation. I really love to, so I think a big applause for Ben. So if we just give Ben an applause, that would be wonderful.
Thank you for having me. That was great.
Yeah, and you're wonderful, and definitely we'll get in touch, and we will see you more often.